Good evening and a warm welcome to Joy News, your home of independent, fearless and credible journalism. My name is Efia Amankwa Tamaklu and you are live on the JoyNews National Dialogue on investing in newborn health, giving preterm babies a strong start. Today, we confront a critical but often overlooked challenge. Every year in Ghana, thousands of babies arrive too soon. For many families, this early arrival becomes a painful struggle, one that exposes the gaps in our health system, the limitations in neonatal care, and the urgent need for sustained investment. Yet, prematurity should not be a death sentence. With the right policies, skilled health professionals, functional neonatal units, public awareness, and a strong media advocacy, we can give these fragile newborn a real chance at life. This dialogue brings together experts, advocates, and parents whose experiences and research eliminates the real cost and the real possibilities of investing in newborn health. This dialogue is brought to you in partnership with African Media Network for the Promotion of Health and Environment and the African Foundation for Premature Babies and Neonatal Care. This dialogue will transcend beyond Ghana's borders. Representatives from Liberia and Nigeria will share perspectives to help us understand how media collaboration across Africa can drive stronger policy action for newborn survival. Catch us live on DSTV channel 421, GoTV channel 125, on all Joy News and Joy FM social media handles, and at myjoyonline.com. Welcome. I will introduce my guest after this break. Stay with us. You are welcome back. You are watching Joy News National Dialogue on investing in newborn health. My name is Efia Amankwa Tamaklu. If you are now joining, you are welcome. Sit down, don't tune off, and watch, listen, and know what is preterm or prematurity. Don't let anybody say something negative about preterm babies to you. Just listen and watch. We have panelists and we have parents who have preterm babies. They are all ready to share their stories and a presentation about preterm or prematurity. So please don't tune off. Stay with us. I have in here my guest, Reverend Steve Mensah. Reverend Steve Mensah is the General Overseer and resident pastor of the Charismatic Evangelistic Ministry, SAME, North Legon. Reverend Steve is a father of a preterm baby. Great to have you here, Rev.
Thank you.
Thank you so much. Then I have my own professor. He was a doctor then, so in case I call him doctor, forgive me. I have my own professor, Alexander Ansan Menu, is a medical doctor by profession. He is currently the director of the Institute of Health Research, University of Health and Allied Sciences, WHO. Professor Menu is a research focused primarily on care of newborns and by extension, their mothers. Yes, so Prof, welcome. Thank you so much for coming. I have a mom, Selina Bintum. Selina Bintum is the founder of African Foundation for Premature Babies and Neonatal Care. Selina is also a mother of a preterm baby. Selina, welcome.
Thank you.
Thank you so much for coming. Then, my own doctor, Dr. Kojo Aho Esel. Dr. Kojo Aho Esel is a consultant pediatrician at the Bank Hospital in Accra. He is also a senior clinical specialist. Welcome, Doc. Thank you so much for coming. Thank you so much. Then on Zoom, so the whole thing is very packed today. Please don't tune off at all. On Zoom, we have our partners from the African Media Network for the Promotion of Health and Environment, Nigeria and Liberia. Rita Giogbe is a national coordinator. Then Liberia. Rita, great to have you. Okay, so Rita will join us shortly. Then I have in Khadija Aliyu, is the Deputy National Coordinator in Nigeria. Khadija, if you can hear me, welcome.
Thank you. Good evening.
Good evening. Thanks so much for joining.
I'm glad to be part of you.
Thank you so much for joining. And also joining us via Zoom is the UNICEF Health Specialist from Bogatanga in the Upper East region, Dr. Peter Kwartin. Doc, welcome.
Good evening and thank you very much.
Thank you so much for joining us. And I have also studio audience, and I'm super proud of them for coming. It's not easy getting these people here in the studio for such discussions. So my studio audience, thank you so much for coming. And if you are here, kindly raise your hand if I mention your name. So I have, hey, I didn't mention a chairman's name. Hey, you let me finish with my studio audience. Then I will come back to Parliamentary Select Committee on Health, their chairman. So I have Dr. Nana Bekai Brackon. He's a pediatrician and the Greater Accra Regional Newborn Focal Person. Nana Memwakwaba, thank you so much for coming. Then, so now I have the honor to introduce the chairman of the Health Committee in Parliament, Dr. Mark Kurtz Nawini. Doc, did I get the name right?
It's Nawani.
Nawani, thank you so much.
Thank you.
You are so busy, but upon a time, thank you so much for also joining us. I have a lot of people here. At the right time, I think I will introduce those people too. But before then, let me take a quick, fast one. I'll be back. Welcome. My name is Efia Tamaklo, and you are watching us on JoyNews Channel, the National Dialogue on Investing in Newborn Health. So we've all heard about prematurity or preterm. That's what we've been hearing. And there are a lot of names that people associate with preterm babies. So this is the right time to also know preterm baby, what they are. They are not in sober as we perceive them to be, and it's not the fault of mothers. Yes, so now it's our turn to have Professor Alexander Ansameno. He is coming to give us the data trends on preterm babies, maternal newborn health, and neonatal care. So he's coming to give us, he is a researcher, yes, while being keke. So he will tell us everything about preterm. So please listen and jot your points down. When the time is right, we'll read comments, every questions you can bring in. Prof, thank you so much once again for joining us.
Thank you very much, Ifia, for this opportunity.
You are welcome.
And good evening to your viewers and listeners on Joy News and on Joy FM.
Yes.
It's a privilege to meet this studio audience, and I say hi to all of you in the studio.
Thank you.
I am also a father of a preterm baby.
Oh.
My daughter was born, and at the time, we look at the thighs of my daughter, and it was like chicken. And so we used to tease her, but I spent a lot of time with her. And for me, the newborn is a group that I particularly love. And I think that as a nation, we should be thinking about investing in newborn health. And I want to give you some of the reasons why we should be thinking that way.
Okay.
So,
okay, so Doc, they will fix it for us. So let's go on with your...
Right, so I want to, first of all, talk about why do we even have to think about the newborn? And I just want to say that the time around birth is the riskiest time for the mother and the baby. So if you think about mothers who die in pregnancy or around childbirth, you will see that most of those deaths occur around the time that they are giving birth, either immediately before the baby comes out or immediately after the baby comes out. And then for the babies, many of them are born dead. So at the time that the baby is born, the baby is already dead, can't breathe, can't move, can't cry, there's no heart activity. And then the third group are those who survive that period, but on the first day after birth, within a few hours, they die. And then some others also die within the first month of life. So you would see that if you look at a plot, there is a gradation of the risk of death from the day you are born as you move along. And you would see that if you compare babies that die within the first year of life, you would see that most of them die in the first month. So I am saying here that many deaths of women occur around the time of birth. I think I've talked about that already. Now, this is some statistics from Ghana. In the year 2000, 67,273. 67,000. 1.5 of the Accra Sports Stadium filled of children died in the first 5 years after birth. At that time, 25,000 of these were babies who died in the first month after birth. So if you look at the first 5 years, there are 59 or 60 months. But in the first month, 25,000 of the children had died already. The rest died between the first month and the 60th month. If we go down the line to 2023, 32,000 babies died or children died before the 5th year. At the same time, 18,000. So you would see that for children below 5 years, between 2000 to 2023, more than half of them were saved. But if you look at newborns, only a quarter were saved. So if you look at the contribution of newborn death to our overall child death, it is increasing. And this is a challenge. The interesting thing I have said so far is that if you look at all children who die in the first 5 years of life, if you are celebrating your child's 5th birthday, and you look at all children that were born at the time that your child was born, if 10 of them died, 5 of them died just in the first month. And that is the issue of the newborn. But the whole issue is about the brain. And I put this there because if you look at a kid of a goat or a sheep, immediately they are born, a few minutes later, they get up and they go to their mother's breast to breastfeed. And the reason is that they have a smaller brain. And so because the brain is smaller, they can give birth to their young ones in a state that they are ready to live outside the womb and survive on their own. Human beings are not like that because we need to have a complex brain that will do a lot of activities beyond what animals do. And for the complexity of the brain, it has to be big. But if we wait for the size of my head of a brain, then my mother can give birth to me. And so we have to be born early and then to have some of the development of the brain occur outside the womb. So the whole issue is about the brain. So what does it mean? So in my mother's womb, this is me. I am protected by layers of skin, of muscles, of fat, and fluid. The inside of my mother's body is always warm. And because of that, I don't think about warmth. I am covered. I am safe from infections. No germs can come to me. I have food from my mother's placenta or after birth. So every time, I don't need to be thinking about what to eat. And also, my mother breathes for me. So blood comes into the baby through the mother's blood, and then the baby takes the oxygen from there. So the baby doesn't need to breathe. The challenge comes immediately you are born. Remember, I have said that for newborns of humans, our brain development is not complete. And because of that, the newborn of a human being is born helpless. They need support to be able to breathe. They need support to feed. They need support to keep warm. And they need support to prevent them from catching infections. And because of these, that is where the challenges of the newborn start. But I'm talking about a newborn who has even reached term. That is 37 completed weeks in the mother's womb and has been born. So if you are born even earlier than this, which is what we are calling preterm, then your challenges multiply. Because there are things that should help your lung to open so that if you breathe air, it will go in and then you can breathe out air. Those things sometimes are not matured yet for the lungs to be able to open on their own. So if you think of yourself choking, that is how when these babies are born and they are not able to breathe, that is how they feel, that they are choking or they are underwater and cannot take in air. 3 causes, as I have said: difficulty in breathing, being born too early, and germs or infections are responsible for the majority of deaths that occur in newborns. And we are talking about between 7 to 9 out of every 10 newborns that are dying. They are from just these 3 causes. How they can breathe, because they've come too early, and because they have infections. But it is not a hopeless situation, because some time ago, the world came up with what we call the 3x2 plan. And that is, if you take a baby that is born too early, you think about this baby, that this baby is likely to be born early, because sometimes there are signs. If the mother goes into labor and we realize that this mother has not reached term, then we should be expecting a preterm baby. And so our preparation as a health system to be able to receive this baby become paramount. So we can give some things we call steroids. And these steroids help the lungs to mature and to open so that air can go in, so this baby can breathe. Other than that, there are other things that for a preterm baby we should be thinking about. Keeping the baby warm, as I mentioned. I would add breastfeeding, because breastfeeding is beyond just a preterm baby. But if a preterm baby or any baby is born and they take in the first breast milk and it's from the mother's body, which is warm, you can imagine yourself early morning, it's cold in the Harmattan season, and somebody brings you warm Hausa cocoa. You can imagine how the feeling is like. That is how the preterm or the newborn baby feels when they get that first breast milk, and it keeps them warm. So we have those 2 interventions. And then if they have birth complications, that is difficulty in breathing, the key thing is that we must have somebody who is skilled to support this baby immediately after birth and support this baby to take the first breath. Because if they are able to take this first breath, it supports everything. The brain will need oxygen to survive. And then other care that we provide to them. And then the third one is if there are infections, we should think about providing antibiotics. And I've mentioned breastfeeding. Now, you'd be surprised that in Ghana, in 2025, we have families who still believe that if you have a newborn, the best way to dress the umbilical cord is to use the dung of a cow. So they follow cattle, their droppings, and they put them there. These then introduce infections. But the good thing is that if we are able to pick these early, then there are antibiotics and various ways that we can intervene. So it's not a completely hopeless situation. But every time that you think that there are solutions, solutions would cost money. And that is why I think that we should be thinking of investing in newborns. Ghana's future are those that are being born today. I was just sitting down and I was thinking the number of people who turned 18 last year. 18 years ago, they were being born. And I can assure you that a good percentage of them died. We don't know what their potential could have been in life. So anytime a newborn dies, the cost for the country is higher than somebody who is older, because we don't know who would be the next President Mahama or the next whoever. So we need to invest in newborns. And it's not just that, because it has a triple return if you invest in newborns. Because what you are putting in place to save newborns also will save the mother. And then it will prevent stillbirth. And it is saving us from childbirth. As I have said, 5 out of every 10 children who die by 5 years are dying in the first month. So if we invest in the first month, we are saving children. Beyond that, there is a challenge in Ghana, which I call the access quality gap. So getting to the facility or providing access to care in the facility is no more enough to save lives. There must be quality. But that gap is there. Because if you look at Ghana, 9 out of every 10 women have attended antenatal 4 times during their pregnancy. Another 9 out of 10 gave birth in a health facility. But the babies are dying. So what is happening? It means that they make contact with our facilities, but they still die. So there is this quality component that must come. And if I say quality, sometimes we only look at the health facility, but it's the responsibility of everybody. The family, the community, the health system, all of us must come together to address the quality gap, because the community must demand quality and the health system must be able to provide quality. So that demand and supply relationship is key in addressing quality. If we want to save newborns, our future must cost us something. There is no way that you would think that I will put nothing in the ground and you would yield something. Reverend Steve, when I was in Legon, they tell us the sower goes to sow. It will cost the sower something. You have corn, you could have used it for kenke. You are deciding that I am going to throw this back into the ground to rot so that I can get something. So if Ghana wants a future for our newborns, it must cost us something. We need the right equipment. Sometimes we think that, oh, it's the health workers who don't care. But they must go to work to have the right equipment to work with. They must be motivated. The human resource must be motivated to work. Motivation is not always about money. And I can tell you that there are many health workers, and I'm not defending the health workers because we have our challenges too. But there are many health workers who have the right intentions about what they want to do for people, but they are helpless in the situations where they are. Infrastructure gaps. For example, breast milk banks. We've gone to the stage where it's not everybody who can have breast milk after giving birth, right? If we can create these banks, then it supports everybody to be able to get that. The other thing that I want us to think about, which is a human rights issue, and I'll talk about what breastfeeding is maternity leave in Ghana. We are giving 3 months of maternity leave, but we are expecting mothers to breastfeed for 6 months. And the next one is that if you go to many of our workplaces, even in hospitals, there is no space created for safe breastfeeding. So you can imagine us in a university, and then suddenly you've come to the university and you take out your breast and you start breastfeeding in the class or where? There are no spaces that are created in many places to allow mothers to be able to breastfeed. So all these things are things that we should think about because it will cost us money to get them working. Like my screen should be working. Right. So, I am stuck here, but I was going to talk about breastfeeding. To be honest...
Doc, please, you can continue.
Good, it's worked. Human breast milk is a game changer. We did some work in Kintampo some years ago, and many people in the Bono East region have heard about the Obapa Vita trial. We followed about 270,000 population with about 120,000 women, and we're visiting them once every 4 weeks. In that time space, we realized that breastfeeding, if you breastfeed a child in the first hour after birth, if you initiate breastfeeding, you cut their deaths by half. Wow. So half of all babies that die, if you breastfeed them within the first hour, you cut half out of it. If you breastfeed the child, it is food from the mother, so you have less allergies, and there are many other complications that we can talk about. The development of the brain is also promoted by breast milk and human breast milk. So if you breastfeed your child, they perform better in school, they have better economic productivity. So you can believe that they have a brighter future if you breastfeed your child compared to if you do not breastfeed your child. And beyond that, it promotes bonding. So there's bonding between the mother and the baby. So I would end and say that we have to be intentional in investing in newborns. Preterm babies are particularly vulnerable. Sometimes we think it is sophisticated equipment that saves lives, but normally it is not. It is the smallest things that we do. The family has a responsibility. I know that in many communities in Ghana, we have something they call asram. And when they talk about asram, they say this is not a hospital disease. In the Bono East region, when we're doing our intervention, we told them that our doctors have now been trained to treat asram. And I can assure you that that promoted facility attendance. We need to get our communities empowered to know that asram is not something that is as hopeless as we thought it was in the past. There are interventions that can save babies with asram in our hospitals. It is not a home disease. So the community has a role to play. And you ask some people that bring your child with asram to the hospital, they said, I can come, but unless everybody else in this community agrees that we should take asram babies. So the decision is not just one individual, but a collective of the community. And that is where I bring community in, that we also have a responsibility to play. And then to the next level is the nation. We must invest in newborns. We must invest in the future generation of our country because they are looking up to us. And the time for that investment is now. Thank you.
Thank you so much. Thank you. Thank you. Prof, please be there for me a little. I believe my panelists also have some few questions or they want to add their voices to what Prof said. So we will come back to you. I hope Rita, Dr. Kwate, and Khadija, you are still on Zoom. So we will come back. Let me take a quick break. When we come back, we'll take some few comments from my panelists, then we'll continue. We'll be back. Welcome once again to JoyNews National Dialogue on Investing in Newborn Health. My name is Efia Amankwa-Tamaklo. We just had a presentation from Professor Alexander Ansa-Menu, and he has really touched a lot of things that I need some few comments from my panelists. So as for my Parliamentary Select Committee on Health today, it has a lot to, because some of the things that Prof said, I think it has to go through a parliament before every other things. So can I start with Reverend Steve Mensah, your comments on the presentation?
Thank you very much, Ifya. This is the first time I've really heard about the numbers, especially the data on how many children die within the first 5 years.
Yeah.
And the numbers are very staggering. It's like 1.5 times stadium full. And to me, that is very worrying.
Sure.
And we shouldn't just allow Prof's data to just be a discussion that will just fizzle out. But we should really take a critical look at the number of children we are losing within the first 5 years and reduce it. I mean, I don't know the percentage for which you can do, but as much as we can, we should mitigate those staggering numbers. They are embarrassing to the nation.
Sure.
And it looks like if we haven't really taken a critical look at the figures they are coming out with, and we spend a lot of money on so many things in this country. But I think that the human life, like he's rightly said, is the future of the country.
Sure.
And we are losing our children, and the figures keep multiplying. So I just pray that this will not be just a discussion, one of those discussions, but it is something that must catch the attention of the nation, and we should critically look at it, invest in it, and mitigate those debts.
Thank you. Let me go to Selina.
The presentation was refreshing. I could literally spend hours listening.
It's not boring.
It's informative.
Professor
And these are the discussions or presentations that we should continue to make sure that stakeholders hear it. We know that our medical professionals know this. This is not news to them.
No,
they know because this is what they are trained to do, to understand and provide care. But for the community and also for the decision makers, they need to understand or listen to some of these issues because these numbers are not mere figures. These numbers represent real human beings. These numbers represent your loved ones and mine, some that we never had a chance to meet. And I always say that even if it were just one baby, who stands a chance or who stands the risk of dying as a result of preventable circumstances, that baby is worth fighting for. Why? Because for that baby or to the family, that baby is an answered prayer. That baby is a bundle of joy to them. And that baby, as long as it's born on Ghanaian soil, is Ghanaian. And I always say that their fair share of the national cake might be that we give them a fair chance to survive and thrive.
Wow.
So I'm happy to hear this, and it's exciting that we are doing this on national television so that those who are hearing it maybe for the first time, they begin to appreciate the issues and understand why stakeholders should not just look at investments in neonatal health as something that doesn't bring reward. They don't see the end because they see there's always continuity. You don't end. It has to continue as a cycle. But something that we need to intentionally invest in and strengthen stakeholder partnership to increase this investment.
Sure. So Dr. Akwejo Esel, you there is not a news to you at all, but do we still have family or parents who think premature babies are cursed and is as a result of maybe the mother didn't do something right? Or after listening to the presentation, your intake?
Well, thank you very much, Ifya, and Prof, thank you for the presentation. So, as you said, these figures aren't very strange for me because we work every day with these figures, so we know them. In fact, let me even add that it said if you are born in this part of the world, you are 14 times more likely to die compared to somebody born in Australia or New Zealand. So we are at a disadvantage when you are born in this part of the world. That's the issue. But Prof made a point that I want to also stress on, that it is not the complex things that save lots of these babies. It's actually the very, very small things. And he said that all these babies, about a quarter of them can be saved by just some feasible, cost-effective care. So one, like, as I said, quality antenatal care. So this quality antenatal care, we have to make sure that every mother, every woman who gets pregnant receive a very quality antenatal care given by quality, well-trained midwives and doctors, and so that everybody who has any risk factor that might lead this baby, this mother to deliver a preterm baby, is first of all pick early so that it can be managed. So, for example, a mother who has her blood pressure going up, a mother who has a sugar issue, a mother who has given birth to a preterm before. All these are mothers that we need to pay attention to. A mother whose water breaks earlier than what is expected. These are the mothers that we need to take care of them. And then during the labor, what is called essential care, we need to make sure that these mothers receive quality early newborn care and maternal care. That is by making sure that they are attended to by quality healthcare professionals who are well trained. The facilities should be well equipped with the basic things that they need to work. And then when these babies are born preterm, the type of thing that she mentioned, early care. In fact, we did a work in Kolembu recently, which we found out that about 90% of the babies who were born and brought to the NICU, for example, were cold. And cold, baby becoming cold is one of the things that will take their life. So these are some of the things that we need to prevent this baby from getting. And then as early as they are born, we need to make sure that those who, as Dr. Prof said, they have difficulty in breathing, they receive the support to breathe, i.e. having what we call the CPAP, for example. It's been proven that early CPAP saves life. And in most of these our facilities, we don't have this CPAP machine to use, and even we don't have people who are well trained to be able to use these machines and all that. And all this comes together. So it is not even about just motivating us, the work workers, but also making sure that we get quality education, skills, train, so that we can perform as well as we have to perform. And then infection prevention, even washing of our hands is a major issue. Sometimes health workers ourselves and parents, when they get to a place where they have to wash their hands before to touch the baby, it becomes an issue. Sometimes we don't have even the resources, the water. You can go to a facility where water has not been filled. I think we've heard this on the news severally, that facilities you go, they don't have water and all that. And it is the easiest way of transmitting infection from one person to the other. And as Prof said, most of these preterm babies don't have any immunity. In fact, they are walking without any protection. So anything that attack them, it just take their life easily. And these are some of the things that we need to be talking about. Even having a medicine called caffeine that we need to give to these babies to make sure that they also breathe well and not giving it. So there are a lot of things that we need to do.
Thank you so much. Let me go to Zoom and talk to Rita from Liberia. Rita, let me hear your comments on the presentation, please.
Good evening, everyone.
Good evening.
So Prof has spoken well. He just reminded me of a research by the Joint Mission of WHO in 2024 that revealed that 36 in every 1,000 live birth, that's at birth in Liberia. So his presentation has made me to understand that the issue is not just unique to Liberia, but it is a regional problem. And as a health practitioner, what I would like him to recommend further is what can the media do in terms of sustained advocacy for maternal leave. Because as he rightly said, it is a major problem in Liberia. You want parents to do exclusive breastfeeding for 6 months, yet maternal leave is just for 3 months. Yeah. So how do we reconcile that? If I am to come to work, not every mother will be able to express breast milk, so say for babies, and not every location in Liberia has access to 24-hour electricity. So when a mother expresses breast milk, she needs it to be refrigerated.
Sure.
If you have limited access to electricity, how do you refrigerate breast milk? So it is something that we all need to advocate about, because as he rightly said, if you are able to breastfeed your baby the first hour after birth, it reduces the rates of death.
Thank you,
It is
Rita.
something that is essential, and I think it is something that I want to elevate in Liberia.
Good. Thank you so much. Let me go to Nigeria and talk to Khadija. Khadija, if you can hear me, your comments, please.
Thank you, Prof, for the presentation. Each point he raised reminds me of certain experience in Nigeria. But my major concern is the issue of exclusive breastfeeding for the preterm babies. Honestly, it's an issue of concern because, like the issue of working mothers, the annual or maternity leave usually starts from like a month before delivery. So the mother only has like 3 months after delivery to take care of the child before going back to the office. So in such cases, if baby is preterm, it will be difficult for the mother and the baby to cope, leading to so many health implications. And we have issues of infrastructures too in Nigeria. Like preterm babies have to be given special care after delivery to keep them safe from certain diseases. Another issue is that the issue of antenatal care. There are still some parts of Nigeria in some communities, rural communities, that women do not go to hospital for antenatal care. So in such cases, if a woman did not go for antenatal care to receive the required medical attention, what if she gives birth to a preterm baby? Sometimes they use culturally cultural methods to take care of their babies, leading to serious health complications. Another serious issue in Nigeria is lack of awareness. There are people, though the media is doing its possible best in enlightening the public, but there are some gaps, like real life experiences of mothers that have preterm babies. What is their experience? What have they experienced from beginning to, let's say, the present situation? Then there are issues of, we have statistics. We know Nigeria has a large burden of preterm babies, but sometimes the statistics are not well presented to the public. There are people that don't know that giving birth to a preterm baby is a problem. They think it's a normal procedure. If a baby is born after 6 or 7 months, they say, okay, we'll take care of the baby. Sometimes there are claims that those babies even grew better than the normal babies, born like after 9 months or 10 months. So there is a problem on ground, but the media is doing its possible best.
Good. Thank you so much, Khadija. And so now let me go to UNICEF Health Specialist from Bogatanga, Dr. Peter Kwatin. Doc.
Yes, Ifya, thank you very much. First to say a big thank you to Prof for the presentation. For us, no better day than this to bring the public's attention to this problem. Today being International Children's Day, where we know that every child has a right to life, right to health, and we as partners need to ensure that we uphold the rights of children every day, everywhere in the world. Just a few comments on what Prof presented. I think that one of the things that struck me most is the fact that the rate of decline in the neonatal deaths has not kept pace with the general under 5. So one of the key things when we are talking about financing, where we do not have enough room in the fiscal space, is that there is data available for us to know where to invest the resources that we have. Secondly, Prof mentioned that it's the responsibility of everyone, the family, everyone. And I think that is one of the key things we are doing today as stakeholders. Dr. Essel in his comments mentioned the fact that Often it's the simple things we need to do. And I believe that we are here today, as we are all trying to do our best, we need to be coordinated, because little efforts here and there, once we put it together, rallying behind the government of Ghana, I'm sure we can address this issue. And as Reverend Steve mentioned, we need to look at these staggering numbers. It doesn't look nice. We really need to save, because every child is important. So thank you very much. These will be my initial comments.
Thank you so much. So let me come back to the studio. Then the chairman of the Health Committee in Parliament, Dr. Market Nangwani.
Yeah. Okay, thank you very much, Prof, for such a wonderful presentation. And you've practically taken us through everything, except I want to point out some area, that is the decline in 1 month. The babies, it did not decline so much. And that, I believe, is because of the contribution of the neonatal deaths. And that aspect. I'm saying this because worldwide we have about 15 million neonatal deaths, and all of these, they are at risk. Like my good friend, the doctor said, they are at risk, and the mortality at that place is high. They contribute a lot to the under 5. And so we see that, and they die within the first month of life. So we see that their contribution is very high. In 2020, I think about 900,000 of them died worldwide. If you take in Ghana here, we had about 120,000 of such births. And out of it, about 8,400 or so died. I mean, this is the statistics we have. And that's the contribution to the 1 month. That is making it not to decline. And so the causes of death for, when you are going up to 5, 4, and the rest, from the years he's speaking about, it's usually due to malaria, severe anemia, and most of these other causes that usually, cause the under 5 mortality to rise. But at the base there, the causes are different. It's because of the contribution of the neonatal births. And I also want to add that most often, at the family setting, you realize that we spend a lot of time arguing about who is the cause, what is the cause, who do we blame for. Even the old woman in our house can be blamed for such an issue. But in actual fact, I must say that, the causes are not very, very strange. But I know that prematurely, you can deliver for any reason. Yes, any reason as well. Like if you're involved in an accident, you get bad news. You go and do some hard work sometimes for some people who are prone to that. Of course, there are genetic factors here and there. But anything can let labor set out and you deliver before your term. And please take note, they should take note of the fact that depending upon, you've got to, some people will say that, yes, I can stay in the house and manage. Yes, preterm sometimes, why not? If you are 36 weeks and you deliver, it's also preterm, but you may decide to stay at home. But what about if it's less than 28 weeks? Or 26 weeks? Can you stay at home and manage it? So the baby that comes out, you just look at the size and know what to do. If you happen to deliver at home or you deliver even in a health facility, and I know in the health facility, usually the health professionals will advise you what to do. And if you listen to their advice, I believe that you can make a way forward.
Thank you. So I think I have to go back to Prof for him to tell us, based on your research, what would you say are the most critical system gaps affecting the survival of preterm babies?
Thank you very much. I think that we have, as we've gone round the panel, we've looked at some of the issues already. And first of all, we have to think about a preterm as a vulnerable baby. The fact that you are born preterm alone increases your chance of dying. Okay. But you don't necessarily have to die. And from around the table, we've heard about various interventions that have been put in place. But what is critical is that it's the simplest things. This baby, we've talked about the key things that will kill these babies. Cold, right? I've seen people give birth in hospital, right? And because they are posh, they decide that they would be in a place where there's an air conditioning. And I've been to a hospital before where I felt that, oh, this aircon is very comfortable for the mom. But for the baby, coming from a temperature of 37 and coming to your air conditioner of 25, it's like being thrown into a refrigerator. Okay. And this baby is getting cold. In our body as adults, if you are feeling too cold, your body shakes, you shiver.
Yes.
And with the shivering, your body generates heat to maintain your temperature inside. Okay. If you are feeling too hot, you sweat. And the body, as it evaporates, then you are able to then cool down your body. Newborns do not have that function, as I said. The brain hasn't developed enough to be able to do that thermoregulation. Okay. So we need to support them to keep warm.
Okay. So
and
this one,
they talk about kangaroo mother care.
So this one's both parents and the hospital.
Yes.
They need to work together.
We need to do that together. Sometimes parents are happy to do it in the hospital, but immediately they go home. We said, just put your baby on your chest. Yeah. Your body temperature, look, we can use an incubator in the hospital, but when the lights go off, the temperature will fall. Sure. In your body, the light doesn't go off. You have constant temperature, well regulated. Sure. Put that baby on your chest, wrap the baby there, and keep the baby warm.
Thank you. So in the studio, we have parents who also happens to have preterm babies. So let me go to Reverend Steve Mensah, so he can share what the emotional and financial realities look like.
All right, thank you very much, MFA. Efia. Sorry about that. A lot of ladies are calling it. But my wife delivered our baby boy, I think at age 22, when she was 23 years. And the boy was born 6 months, 2 weeks. Okay. And the weight was like 1.2 kilos or something. Very, very tiny. And I was like 26 years old.
Was he the firstborn?
I was the second.
Okay.
And the firstborn was like 1.4 or 1.6 kilos, but this one was small.
He also was a preterm?
She was also preterm.
Wow.
But she made it through. She was a girl. But the boy was smaller. And at a point, I almost told the hospital to keep the baby.
Oh. Were you still Reverend or? Oh my God!
Because I hadn't seen such a tiny baby like that before. Very tiny, small, and fit. The baby could fit into my palm.
Wow. Yeah.
And when I went to see the baby, they had covered the baby with some blankets and things, and I was very emotional when I saw the child. Went to tell my wife, and broke down and all that. In fact, because we were a young couple, we were just married about a year or two. It was very challenging for us because we're not even prepared. We were not cool. We were not prepared that we might have a preterm baby. So it took us by surprise. And the child stayed in the NICU for about, I don't remember, maybe 2-3 months. And when we brought him home, he was very small. You know, the muscles around the mouth was not developed enough to suck the mommy's breast. So my wife has to use syringe or something to be, you know, and it's a very depressing sight to see a helpless boy wrapped in this thing. And And I thought that I was saying, honey, are you sure this thing is going to be all right? Because you couldn't feed, you couldn't cry, he was always shivering. Like the Prof said, I think that he was always shivering, he was always wrapped, and they have to be feeding. And sometimes my wife would be feeding the baby and crying at the same time. Oh. And all that. It took him 3.5 years to walk.
Wow.
Yes. It took him 5 years to learn how to speak.
Wow.
It took him 10 years to go to school.
Wow.
And he was always sucking his breast. And then the gap between his ear and the nose didn't develop very well. So he always had a discharge in the ears, and he was constantly in pain and constantly crying. He cries from morning till evening.
Wow.
You see, because we are new parents, we don't really know what to do, what was happening to him, why was he crying. The man would come and give the baby to me a little.
I'm not cutting you, sorry. And I think at that time too, the education or the awareness was not...
I don't know at all. We didn't have, even we as parents, the doctors didn't sit us down to tell us how we are going to manage. It was just there, and then we were asked to go home and bring the baby back after some time and all that. And I must say that if you go through that thing, you'll be so traumatized. Yeah. Today we have a lot of discussions, knowledge has increased. We have a lot of social and medical support, but this is 32 years ago. We didn't have all those interventions. So it traumatized us a lot. The baby was always in pain. That's one thing, always in pain, always crying, because we are trying to put pacifier, you are trying to breastfeed, and they discovered that there was an infection in the ear through the nose. That gap didn't form very well. So he was always crying. We were giving a lot of medications and all that. And at the point, I have to ask my wife to stop work. Otherwise, this child will just pass. So she stopped the work to look after the boy and all that. And I don't know whether you want me to continue, but...
So what next?
Okay, so after 10 years, he started going to school. And I don't think he was aware of where he was or why he was being taken to school. He was totally lost. And his thumb was always in his mouth. And at a point, he was screaming at school, I want my mommy, I want my mommy. So they would call me, and I would call the mom. The mom was working at the bank. And the mom would take permission and come and pick the boy and bring him home. And he was at the bottom of the class throughout. Every class he went, he was last. He was last, totally last. If they are 40, she's number 40. If they are 30, he's number 30. So I stopped looking at his results. I said, just learn how to...
So now, how is he?
Today, by the grace of God, he's a pilot.
Wow.
Yeah.
Yes.
Hey.
Yes, he's a pilot.
D40, you know, you're a pilot. Wow.
Yes,
God is wonderful.
Yes. Even his teachers came to me and told me that my child, because his brain was slow.
Hey.
If he was celebrating his birthday and you asked him to blow the candle, he wouldn't know what to do. His friends would blow the candle for him. And then if he was in a musical chairs, the music would stop playing and he was still dancing. But there was a moment of change in his life when the teachers came and told me that I should discourage because I bought a toy plane for him. And he ran to me and told me that he was going to be a pilot.
We'll come back to you. Rev, your story there, we should leave you to talk
That's why I say that.
Hours. Wow. Let me go to Selina Bintoum. You should tell us the trends of challenges. Yes, because you've been seeing those mothers.
Yes, and it's not just the mothers. We have to remember they are in a family unit. And I think that we would often assume that the fathers do not feel same or even more emotional trauma. And I think that is an important part of Rev's story. And that we make it easy and safe for men to join the discussion when it comes to the journey around preterm birth. So you would often see that, or hear stories and feedback that some of these babies have been abandoned by their families in the NICU.
Wow.
And these are the realities. And I think a couple of years ago, we met a baby who is being raised by medical doctors and the nurses in the facility because the mother passed and the father abandoned the child and the immediate family abandoned the child. And so this child knows the parents, the doctors and nurses as her parents. And we often, we had an experience in one of the places we went to. I remember the story was shared with me and I noticed that, you know, some of these trends of abandonment or parents explaining the trauma, they go to the father, we are not prepared enough. For the men, you can always trace it. There's no excuse to abandon a child or the mother. But you would trace that in their bid to express fear and the fact that they feel weak and unable to provide the protection, the guilt, or having to do for some, running away might be the best option, even though it is not supposed to be the case. And then you would find that in my case, for example, when I went to the NICU and I saw, they said, this is my baby, I burst into uncontrollable tears.
Wow.
Because I didn't understand why I was seeing so many things like this. And for most of the mothers or families, the trauma, the fact that we are not prepared, unless you have a medical condition.
So tell yours.
Oh, my story. I woke up one dawn as a pregnant woman. I just entered the second trimester. Yeah, about almost 7 months. And my water broke. I think Doc mentioned something like that. It's called the premature rupture of the membrane, PROM. Okay. And I found about this afterwards. And I was rushed to the hospital. The doctors put me on bed rest. They were contemplating between inducing labor or emergency CS. And because I was losing so much lico, the doctor, I believe, with all good intention, wanted to force labor. And the midwife, I believe, was an angel God sent. He said that, Doc, we will not force labor, rather emergency cesarean. Okay. It was during the procedure they found out that my baby had tied his umbilical cord around his neck twice.
Wow.
He had undescended testicles. He weighed 1.4 kilos. And the only thing I remember I saw, it looked like his skull looked like its plates is not formed. So you can see that it's not together. And we were separated for about 5 days. When I joined, the same thing that Rev was saying, they are tiny. This is how small the baby is. You know, it's just like you're buying meat 1 kilo and they give you extra. Oh. You can imagine the weight of that baby. And when I saw him, I said to myself, this will be a miracle if this baby would survive.
Was he your first child?
Yeah, that's my first child. Oh. And he couldn't suck, he couldn't do anything. But I believe it was a miracle that my baby survived because he started doing very well. His testicles dropped. And for him, we were discharged earlier than anticipated because he was doing well much bit faster than the medical doctors had predicted. And so we are grateful that we were able to discharge. Now he's 10 years, doing amazing, and he's an inspiration. Himself and other mothers and families are inspiration for what we do at the foundation. So we look at the trends, and an important part is the cost of care in the neonatal intensive care units, a silent killer. Because most of the time we are all talking about, the fact that we don't have this, and Prof said it, and Doc also emphasized, the simple things. The cost of care in the NICU, if you're looking at trends, and some of the mothers here would explain to you what the realities of the cost of care is. Because NHIS is not covering the essential part of the care that is required to keep the baby. The caffeine and other medications that our senior medical experts here, doctor, will mention, that these are paid out of pocket by parents. And as long as it's not covered by NHIS, ask if there is a parent who is working very hard, sells fun yogurt, pure water, and has to welcome the baby, cocoa seller, hard-working, but have to buy medication that costs more than 250 Ghana cedis.
Where is she going to
and has to buy it multiple times.
Wow.
So that is another issue. The other issue is the fact that if the woman or the mother can't afford this medication, it means that that baby's survival chance is slim.
I'll come back to you. Let me go to Dr. Kojo. So tell us the key life-saving interventions that can sustain our little angels.
I would have loved to say something about reference issue and then Madam's issue. It is about the emotional trauma that the parents go through. Because, look, nobody plans to be pregnant and then plans that my baby should come out very soon. Everybody plans to have a 9-month pregnancy with what we call a bouncy baby and all those things. Now, this baby would have come out earlier than it was planned to come out. Then the mother gets to the NICU or the father gets to the NICU and you see all these gadgets, these equipment with all the alarms beeping here and there, with cables all over the place, with babies on all sorts of gadgets and machines. That one alone breaks them down. Again, they might not have been prepared enough, counseled enough, spoken to about the preterm and the journey ahead. Because the journey can be very, very long. Reverend said that his baby stayed there for about 3 months and all that, and some can stay there even more than that, depending on how soon you come out. Okay, so these are issues that parents actually confront. And then the cost bit of it she mentioned is a reality. In one of the facilities I work, there's a medicine that the mothers call is cocaine. There's a medicine they call it cocaine, and that medicine is used to treat infection. Okay, because when every other medicine does not work, this is the medicine that the doctors will want to use to work. And that medicine, if you buy one today, your salary might go. Is that okay? And it becomes an issue. So some of these things, maybe health insurance will have to come, but the emotional trauma, the fathers, sometimes even the mothers are better compared to the fathers. Because the father, one, he has to now take care of the mother, take care of the baby, and also make sure that he's getting money to be able to pay for some of this care. And so sometimes they even come to the facility and come in shouting, behaving abnormally. Somebody who might be a very respectable person in his community or his work on whatever, but they come in and then they even ask you to discharge your baby to go home because they want to go home. But that is not the issue. Most of the time, I tell my younger colleagues that is not the issue. The issue is financial. Sometimes they cannot even afford. But whenever you give them that opportunity, you sit down with them, you talk to them, you bring even psychologists to come and help. And that's one of the things that helps. So we even have a few psychologists around that can do all this job. That is it. But what are some of the basic things that we can do to help these babies? So as I mentioned earlier on, about 3/4 of these babies can be saved by just some evidence-based, feasible things. The antenatal care will mention, making sure that they get the steroid, as Prof mentioned. These days, there's something called even magnesium sulfate that we give to them so that their brain, as Prof mentioned, will grow and grow better.
You are not giving to them freely?
Yes, but for the magnesium sulfate and steroid, they're quite a bit okay for parents.
Let me go to my chairman. It's good that he's here because what we are discussing, it's all boiled down to NHIS. So, my chair, we want to hear from you. Maybe from today, you have to discuss it and see the way forward so that we can include something on neonatal, what do you call it, prematurity babies on NHIS.
It's true. During my usual rounds and other hospitals, Kolebu, Rish, and so many other hospitals, actually we stumbled upon that problem where I think one patient even said, I think they are spending up to 1,000 a week.
Hey.
1,000 a week, and that even sometimes they spend more than that. And so like they are saying, and they also stay there for a long period. So it's not just 1,000 a week or something for just 1 or 2 weeks, but probably for months. And without knowing whether you are going to get through or not. And so we picked up the issue And we had the explanation that most of the drugs are not available. They have to buy it. It's not on the NHIA. Apart from that, they need a lot of gadgets. The oxygen, the water, so many monitors around. And all this have to be maintained. And so we understand the issue, and we have started advocating that as part of government policy, first and foremost, they should spread the neonatal intensive care unit across the country, even to district hospitals. And if they need be, then of course they can refer them to the regional or the teaching hospitals. We are saying this because some of them come from even far away and have to come and stay at a hospital that is not near to where they hail from. And that alone by itself is also a cost to them. And sometimes, I mean, if they are like first child and the rest, very soon see the man will also come and join. Unless probably it's the third, fourth, or fifth child, sometimes you realize that the man stays away. So we are advocating that they should spread it across the country. And of course, they need the support of the social services. Yes, they need that support as well.
Okay, so I think I will come back to you again.
Yes.
What do you call it? The maternity leave.
Yes.
Yeah, that one too. I think you guys have to work on it for us.
Yeah, so we are advocating very seriously.
3 months is so small for...
to get it onto the National Health Insurance bill.
Paternity leave.
Maternity leave.
And maternity. Okay.
We want to look at the items one by one and see what can be transferred onto the NHIA list.
Yes, thank you. Let me go to Nigeria, Khadija. I think Khadija makes some comments like they have challenge there in Nigeria. So I just want to know what the media there is also doing so that the government will hear and do something about preterm. Khadija.
Thank you. I'm really enjoying this program. I hope to have more opportunities like this. So what the media is really doing, we have been amplifying such cases of preterm babies, like through feature stories, special reports, advocacy, just like Remapsen. We advocate to policymakers to ensure that all these things are captured. I could remember an engagement we had some few months back. I represented Remapsen in a program, on a health program that has to do with maternal, newborn, and child health. And this issue was raised. We, the media personnel, because it's a coalition of media and civil society organizations, we came together, we formed a coalition. We formed a coalition against these childhood killer diseases. We provided action points on what will be our contribution to this cause. And God's willing, this advocacy is yielding positive results. Like recently, there was a coalition of journalists against polio that was inactive for many years. We are able to secure the approval of UNICEF to revive it back. And we'll not stop at that, like this issue of preterm babies, since it's an issue that has to do with child health. So we are forming another network that will bring civil society organizations, just like Remapsen, to work under one umbrella to amplify our messages, to ensure that policymakers are held accountable, our stakeholders contribute their quota, because we believe as a stakeholder, if the issue is just left to the policymakers, it won't yield positive results. So as a policymaker, you have to have a role to play. So we are doing our possible best and will not relent. We'll continue advocating till we achieve the desired objectives of reducing childhood, prenatal, and all these issues that has to do with childhood killer diseases in Nigeria.
Okay, so let me go to Rita, Liberia, and see. I can see it's no different from what we are discussing here in Ghana and Nigeria. Rita, let me hear from you, please. Is Rita there? Please unmute so we can hear you, please.
Are you getting me?
Yes, please. You can hear you now.
So, like I said earlier on, the challenges are not just unique to Liberia. They are everywhere. But the media here is doing extremely well in highlighting some of these issues. For a typical example, we woke up one morning, or the entire Liberia woke up one morning to this headline: one incubator at Liberia's biggest referral hospital. Can you imagine that? The biggest referral hospital in Liberia, the John F. Kennedy Memorial Hospital, had just one incubator. Wow. And that story came about when a mother took to Facebook to talk about how she lost her baby at the hospital because the only incubator there was already occupied by another mother. So her child had to be on the side waiting for that other child to be out of the incubator before the child can have access. Unfortunately, she lost her baby in the process. Wow. And the media highlighted that story. One morning when everyone woke up, every front page of major dailies in the country had that headline: one incubator at Liberia's biggest health facility. And as a result of that advocacy, I can tell you that at major health facilities in the country, we have incubators in Liberia as a result of that advocacy. And not just that, at some of the health facilities in Liberia, especially in remote places, we have challenges with roles. Pregnant women.
Hi, Rita.
Have challenges with accessing the maternal waiting home. Hello, are you there?
Yes, please. We can hear you now. It's the network.
Maternal waiting home was not common to all of the regions in the country. Pregnant women had to be transported in terms of emergency. They had to tow them on hammer, what have you, to take them to the health facility. And because of sustained media advocacy, right now, most of the maternal waiting, facilities in remote areas have maternal waiting homes, where when a pregnant woman enters her third trimester, she moves to the maternal waiting home to await the arrival of the baby. And that, according to health workers, have reduced the issue of maternal and newborn death as compared to what we had before. And instances of ambulance, places that there were no ambulance and what have you, the media has really been doing well, and also leveraging social media. Knowing that on social media, we have diverse audience, we have the policymakers, we have the newsmakers of all ages and what have you. So what the media does in Liberia to create more visibility on these issues, after reporting these stories, we do an explainer and post on the various social media pages, share with bloggers, reduce the stories to our local language, that is the colloquial, the simple Liberian English, for every Liberian to be able to understand. So that's one way the media has really been helping to attack or tackle the issue of maternal and newborn death in Liberia.
Okay, so let me again go to Dr. Peter Kwarteng, the UNICEF specialist. Let's see what UNICEF is also doing in terms of investment with regards to preterm. Doug.
Right, so thank you very much again, Ifya. For UNICEF, I would say that as a development partner, we work closely with the government, pushing the government's agenda, not a separate agenda. And so what we do as part of the UN Development, Sustainable Development Cooperation Framework, we work together with the government of Ghana.
Dr. Kwarteng.
Can you hear me, please?
Yeah, the network, the line is breaking. It's not so clear. Can you please shift a little so we can hear it well?
Is it better, please?
This is better. Please go ahead.
Great. So I was saying that as a development partner, we work closely with the Ghana Health Service and the Ministry of Health. And I must say that we've realized from the discussions ongoing that it's not just about quality of care, but it's also the experience of care. as parents were sharing some of the experience they've had in the pandemic. We have worked together with the World Health Organization on a 10-step approach to scaling up care for small and sick newborns. And some of the things that we have highlighted are clearly there.
Okay, Dr. Peter Kwarteng's network is not so good for us. So I will come back to my studio audience. They've been so patient to us. Let me go for a quick commercial break. When I come back, we'll continue. Welcome back to JoyNews National Dialogue on investing in newborn health. I believe my audience or my viewers and listeners are enjoying the discussions and the stories that we are getting from our mothers who have preterm babies. Wow, the stories are interesting and inspiring too. So in case you have one, no, don't give up. Now yours is better because 32 years ago, there wasn't any awareness and panel discussion like the way we are doing now. So ours is better than before. We thank God. And now I think I have to go to my audience, my studio audience. They've been so supportive, quiet, and enjoying the discussion. So I have to go to Mr. Ibrahim from Water Aid. Let me hear from you. Any comments? Your suggestions to what we've discussed so far.
Thank you very much, Madam, and your esteemed panelists for digesting the issues. For Water Aid, we have been connected to this discussion since last year with the AFPNC. And why is Water Aid connected? I think Prof in his presentation touched on neonatal infections. And Water Aid, as an international organization, we dedicate part of our support working through government systems, supporting especially rural CHIPS compounds and healthcare facilities on a program we call IPC WASH, Infection Prevention and Control. And as Prof was presenting, I mean, the top 3 neonatal infections was predominant. Why do we have neonatal infections? Basic availability of water, hygiene facilities, and sanitation will save the situation. Sure. And so in most parts of Upper East region, in many healthcare facilities, the last 10 years, Water Aid has been investing in supporting CHIPS compound with basic water. And I tell you, this year, still on this same similar platform created by JoyNews, we did a documentary called Mothers in Peril. And the documentary captured in our program areas the difference between mothers who attended antenatal and postnatal, where WASH facilities was, and then those who attended without WASH facilities. And in Garu, in Bongo, in Boku West, the mothers who attended antenatal and delivered in facilities where we provided WASH. In fact, at the point where they were decided they didn't want to go home because we piped the water through every point of care. And that is what Ghana Health Service, Ministry of Health, call quality of service.
We'll come back to you. Thank you for your submission. Let me go to my one and only Dr. Nana Brako. As for him, all the premature babies are his.
Hello.
Nana, we can hear you, please. Yes.
Hello. So, thanks. I'm seated here, and I've enjoyed the conversation. Starting from Dr. Menu with his brilliant presentation, and then the panel discussion, which really went on very well. But I think from where I'm seated and for where I'm representing, I think I have a little to say. I'll say that data shows that from 2012, the neonatal mortality rate was around 31 per 1,000 live births. And before we ended the MDGs, that's Millennium Development Goals, we have dropped it to around 24 per 1,000 live births. Now, in 2022, the Ghana Demographic Health Survey gave us a data of 17 per 1,000 live births.
Okay.
But if you are taking data and you don't take it from the same source, sometimes there can be a bit of discrepancies. So we went back to our UNICEF data collection, and we realized that as at present, we stand at 21 per 1,000 live births. So if you take from now till the end of 2030, where we think the SDG, Sustainable Development Goal 3, which talks about the area that I want us to hit is neonatal mortality, dropping it from to less than 12 per 1,000 live births. I think we have a long way to go, because if we really stand at 21, then it means we need some rapid acceleration kind of interventions to be able to meet it. So we are still not sitting, we are working towards that. So we've put in some high impact, cost-effective measures such as preconception, antenatal skilled delivery, neonatal resuscitations, sepsis management, KMC, safe oxygen, and then thermal control, that's hypothermia. But this is not across the country. It's just at something like pilot regions and specific hospitals. And with that, we are not going to meet the SDG. So we need universal coverage of these interventions, where we need high impact, rapid response or rapid outcomes that would let us get there. And for that, there are some very few things that you need to do. You need to work around delivery, okay, and then around the early neonatal period. And then I think we can get there. There are four major things that comes to play. Infrastructure, which is long-term, but it could be medium-term if you only want to do expansions and some renovations. For short-term, we have to make sure our drugs are available, drugs that can save babies, and they are not expensive. You need your caffeine, you need your dexamethasone, that's caffeine for this breathing, dexamethasone for the lungs, you need sulfate for the brain of the babies, and I think it will be good to go with those basic ones everywhere around the country. So NHIS now comes to play, that all those things should be ready and they should be available for our people. Now, the next thing is what? Equipment. And equipment, you need pulse oximeters, which I think they're affordable. It's something doable. You need your bag valve masks, what we call the AMBU bags. They are affordable. We can get them across the country. We can get in every institution.
Is it the affordable, is it? Are you talking to parents or government?
I'm talking to government because it's affordable.
By the way, you are saying affordable, like
yes.
mothers can afford to.
It's affordable. Okay. It's affordable. It's doable. And then we need the last but not the least, CPAPs. And by the grace CPAPs, UNICEF had worked with the country, and they've brought a very high impact, cost-effective CPAPs called the Value CPAPs, and they are performing magics. So I think something can be done, but it falls down on what? Health financing. Okay, thank you.
Thank you too. Let me hear something from Dr. Sally Menu.
Yes, thank you very much.
Thank you.
I think Nana has just sort of mentioned what I wanted to talk about, which is health financing. I think that, like Prof said, we really have to be serious as a nation. We really have to invest in newborn care. We must get to the point where we are heavily subsidizing newborn care. Because like I always say to my colleagues, newborn care is not cheap. And if you get the experience of practicing in a place where there's there's no out-of-pocket payment from relatives or from parents, and then you come to the system where, more than 50% of the things have to come out of pocket, it's really a problem. I think we really have to get to the point. Like Selena said, there's a silent killer. Sometimes you will find that the reason why one baby will survive and the other won't survive is just because one parent is more stable financially compared to the other. So if for nothing at all, one of the things or the take-home messages I want to, let our head of Parliamentary Select Committee on Health is that we really have to get to the point where we are prioritizing newborn care and where we are heavily subsidizing it. Yeah, thank you.
Thank you. So those were my studio audience and their submissions. I believe I have some social media comments. I'll come back to that. I don't know. Let me go back to Prof. As for research, it's not today that we are hearing it. So how do we integrate that one? Because you come and present, at the end of the day, we don't see anything. So what can we do? Or what do you suggest?
Thank you very much. I think that over the years, our focus is changing from research just for publications, and we are now moving towards working within the system to find system solutions to our problems. And I think that should be the way to go. When I listen to Reverend Steve's story, something strikes me. Two things. One, I think everybody's talked about mental health support to mothers and families who are faced with this. But even health workers. Sometimes health workers come back, and I've met Dr. Bracco sometimes looking very miserable because he's gone to see a baby and the baby is not doing as well as he's expecting. But we sometimes think that the health workers play God. But there are times that you lose a child or you lose a patient and it stays with you for weeks. I was talking to some people in the Bono East region and they said, this woman is somebody I go to church with. This woman is somebody that I go to the market with. Our children go to the same school. And this woman has come to die in my facility, or the baby's died in my facility. And then I go to the market. Or they are coming for the funeral service in my church. How do I go? So health workers also have challenges, but I'm not absorbing them. But the other thing that struck me was that ordinarily, our system in Ghana would expect every child to do well in school, do math, do English, do this. But when there is good placement of children, then you can see that we can get a pilot. Because otherwise, would have said it's a failure. It should stay at home. And so we should start thinking that when we have preterm babies, or when we have newborns with complications, they may lose some aspect of their lives, either due to delays or some other causes, but they have not lost everything. Our judgment of what they can be should be based on assessing their capabilities. There are some babies that I said, they couldn't breathe early, they get asphyxia. Asphyxiated babies, some of them get cerebral palsy. Some of them are in wheelchair throughout, but there are systems to put in place for them to do other things. We've had some who are computer gurus. And so I just want our system to start thinking beyond our normal way of thinking. And if we think about newborns, we are thinking about preterm babies, we should start thinking about a multidisciplinary team that is taking care of not only their immediate needs, but also planning for their future and giving them that seamless transition through life, because they have the potential to be economically viable and productive. And I think that is where our system should start. We need to rethink our health systems.
So I think I have to go back to UNICEF, Dr. Peter Kwarteng, and let's also hear his submission. Dr.
Thank
Kwarteng.
you. I hope my connection is better now.
Yes, very well.
Great. So I would be very brief, and thanks to all our panelists for the inputs made so far. I would start with one thing that Chairman of the Parliamentary Select Committee, Dr. Mark, mentioned, that looking at the fact that I want to spread out the newborn care units across the different districts. So there is some work we have done. I started by saying that UNICEF supports government's agenda. So there is some work we have done with the Ghana Health Service, supported by Prof. Menu and a team of very seasoned researchers across 154 of our districts that reported having newborn care units, and a total of 185 health facilities. That shows clearly the gaps across the country. I believe that this will be a very good point to start the discussions, and thank you for putting this together. As Reverend Steve said, we need to see action from here. UNICEF has done a lot of direct interventions in terms of provision of equipment and all that. But I believe that going forward, it's a multi-stakeholder involvement that is needed. Other partners have also come in. But if we will all rally behind the government of Ghana has done a lot. Even the president more or less convened the African Health Sovereignty Summit. And I believe that we have a ship that has set sail. And all of us need to support the government to be able to address these challenges. On our end, we'll be happy to start engagement on the assessment that was done and see how we can rally everyone on board to ensure that we don't lose any more lives. So thank you very much from my end here. Thank you.
Let me come back to Reverend Steve Mensah. So after 32 years, I believe some parents also are listening and watching as well. They are going through the same wahala that you went 32 years ago. But now you are here, you have a pilot. So tell us and say something to motivate someone who is watching or listening to us with this condition.
Well, thank you very much, Ifya.
Yes.
Well, like I said earlier on, the school-going age was very terrible. My son was always last in class. He was always lost. And he went to, as I said, just go through the system and see what you can do with your life, because his brain was slow. He doesn't see things or hear things easily. He doesn't act on things very easily. So
what was the magic? What did you do?
It will surprise you that his teeth, like I said, I bought him an airplane. He was just playing with it, and then he came to me and said, Daddy, I want to be a pilot. I said, oh, really? Please go and play with your toys and just be happy with it. Because I realized that if you want to be a pilot, you have to be like this. You know, and he was very slow. So he went to school and they were asking the children, what do you want to do? I want to be an engineer. What do you want to do? I want to do. Then they asked, what do you want to do? He said he wants to be a pilot. And the whole class laughed at him. Oh. And because they all knew that he was always last in class and there was no way he was going to be a pilot. And then the teachers came to me that I should discourage my son from thinking that he wants to be a pilot. Oh. So I said, I know my son is slow, but you don't have to come to my office, come and remind me of my pain, that my son was there. So just let him be in the class and let him become what he wants to become. But when he left, then the scripture, Luke 1:37, I will never forget it.
Luke 1?
Luke 1:37. It says, but with God, nothing shall be impossible. That's all. That was the game changer. That scripture was the game changer. I went back home, called my son, held his head, said, you become a pilot. I started praying for him. And miraculously, his grades and everything started changing. That positivity, that encouragement, because I used to dismiss the things he wants to do. But after that scripture, I just didn't know. And from there, he wrote to the school, Paddleton School in Emirates. They took him, he passed his exams, he went there, they asked him 350 questions about himself, he got about 90%.
Wow.
And since then, he just broke through. And as I speak to you now, my son is a private pilot license and commercial pilot license.
Wow, 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 wow. Hey! Wow, let me come to Selena. It's not easy. You see how Rev is motivating us. You two, what worked for you? And again, I know there is stigma all over. So how do you do away with stigma and also something to inspire those watching?
So for the foundation, the last 10 years, what we've dedicated ourselves doing is encouraging stakeholder partnerships. Why? And I think that our healthcare professionals, senior healthcare professionals, I say senior because they've seen a lot. And they've emphasized that, and from their submission, you can see that they can't do this in isolation. We need them. In fact, they are a critical part of the survival process. So our parents, when we say community, we're not just talking about the chief and its people. We're talking about industries that produce products and services that target women and children as well. Then we come to government. So we have 4 key players, and also community includes media and any such entity whose work influence policies or affect our lives directly. We must collaborate so that we will be able to consolidate the initiatives. Dr. Bracco mentioned that there are initiatives that are happening, but they are in pilot phases. And as I speak to you, there are organizations, APEC is here, they are tackling preeclampsia. You know, there are organizations that are doing different things around neonatal maternal health. How do we consolidate, like UNICEF said, how do we consolidate these efforts and align these initiatives to government's vision, so that we don't work in isolation, we can actually tackle this issue together. That is why we are advocating for a national action on prematurity. Let's put a name to it, so that we bring stakeholders together, that periodically, based on this action, we are all aligned, and government is showing leadership. So with the Ministry of Health, together with CSOs like AFPNC, we help bridge the gap between the community and government and the healthcare professional. So what we are saying, what we're advocating for is, and we piloted this through the Purple for Prematurity Summit. And I have to commend multimedia, that this is the only media organization that, in my experience, the last 10 years, consistently offered platforms to civil society organizations like us, because we can't afford to do this. We can't pay. When you go to some of them, they expect you to pay before they can grant you audience. But with multimedia, from the first person at the reception to the highest person I've engaged them, you people have been amazing.
Thank you.
Amazing, amazing. And I have to say that for the whole month of November on Joy Prime, multimedia partnered with us with the support of Pediatric Society of Ghana, SOGOG, which is the obstetrics, the Ghana Psychological Association, and also, I think I've left one of them, GRNMA, nurses, and under their leadership, they've supported us to bring information to the public. So for the past 3 weeks, we are educating public, and we pair healthcare professionals to parents. Why? Because I always say that when science communicates without a social aspect of it and a real impact story, it doesn't make sense to the everyday person. When Doc and his colleagues are discussing, they understand the language, but once it gets into the public domain, we get confused and alarmed. But immediately I share my story, Reverend Steve Mensah, as influential as he is, when he speaks and shares his story, it doesn't make sense, it feels relatable. Everybody will feel that, oh wow, it's not that bad. So when we can collaborate effectively, celebrate our milestones, because indeed, Dr. Bracco, they are doing amazing work. Let's celebrate the work the healthcare professionals are doing. Pediatric Society of Ghana, they do fantastic work. Let's collaborate together and not put each other healthcare discipline down, so that we can align and make sure that we can achieve the collective goal here for the country, for our small babies, for our babies born too soon, sick and small.
So let me go to Dr. Isel. what's working for you? I mean, if I say you, professionals, because Professor Menu said it, that though parents are going through stress and stuff, yours is worse because you have to save the babies and also talk to mothers. So what's working for the professionals too?
Okay, so what worked for us, I don't know what's worked for us, but I think the calling, the passion, the responsibility that we have as professionals that sort of sometimes keep on going, because if you also want to share experiences as health workers, what we go through from that tiny baby, for that mother who had been expecting babies for a very long time, he's not conceiving. Now he conceives, and then the baby comes as a premature baby, and then he comes to you and say that, doctor, that baby has to go home. Wow. I have to take baby home. So recently I have one like that. She came and said that I have to take that baby home. So that's become a responsibility on you. And that baby was very tiny. And then per the statistics that has been given out, it's a baby that per our books, he shouldn't make it. Yeah. But the challenge was thrown to us, and we had to work. So what it meant was that even you don't have a free time. You have to work extra hours. You have to be there for the baby. You have to be there for the parents. You have to be there, talk to them, and you yourself make sure that you keep on going. It's not an easy job. Losing a baby, sometimes you feel like you've given it your all. You've done whatever you want to do, and baby goes, and you'll be thinking what you could have done best and not. And sometimes it is out of your control. Some of the things that maybe you would have loved to have to use, you don't have them available. Some of the medications that they've been mentioned, some of the equipment that you've mentioned, the CPAP, making sure that the incubator is okay. And yes, incubator is fine, but these days KMC sometimes also helps. So we now advocating more for KMC, making sure that there are basic things for you to wash your hands and clean your hands and all that, so that you'll be able to move from one baby to a baby to that they don't pass on infection. Making sure that that baby, if you use this particular antibiotic is not working, you'll be able to use the other antibiotics without going through any stress. Because every now and then parents will come, they don't have the money. So as Dr. Amenu said, sometimes the difference between one baby surviving, the other baby surviving, is just because of a bit of financial what we do with the other side. And then also making sure that at least there's somebody to support. Sometimes if you go home and you go home as a health worker, then you don't even have a support. That alone, because sometimes you go home very tired, very exhausted, drain out and all that. Especially with those who work with the preterm baby, it's not an easy job. So it's not an easy job, and if you don't have the things to work with, it becomes an issue. Everything that we are talking about, our
so I think I have to go to Dr. Nawani. What is government doing, or what should he do? Because this one, we don't want any long term. We need solutions. We need answers.
The government of the day is a listening government, I must say. And we are fighting to increase the funding of healthcare. If you look at this year's budget, it has gotten to 22 billion as against 17 billion the previous year. The decapping of the NHI has brought in more funds. And that is why we've been able to put some aside for non-communicable disease under the Mahama Care program. I believe that a program like yours is sensitizing all of us. We went around, we heard it, we saw it, and today you've been able to get me here to join you in these discussions. Before I came, I looked at the statistics, actually, what it meant, for a country like Ghana. And it was not very good. And like my colleague doctor opposite mentioned, we need to set up more centers, neonatal intensive care units, standard ones, with good monitoring teams to do that. And how do we then help people to patronize it? And that's where the healthcare financing comes in. And so we are going to, indeed, I believe that within the next 1 month, we'll be meeting the National Health Insurance Authority. And I am going to personally request and ask why NICU or neonatal intensive care, that unit is not under NHIS. The truth of the matter is that a lot of the things actually come under NHIS, but because of poor tariffs, that is what is making them, that answer to always come out, that this one is not there, this one is not there, this one is not there. An actuary study has been carried out, and we hope that we will have to increase the tariffs of the health the providers to ensure that this so-called co-payments or illegal payments or under-the-table payments that we do at the hospitals, we put a stop to it. But that depends on the implementation of the actuary study, which shows that the current tariffs are not enough and that we need to improve on the tariffs. So let's hope that these discussions, this is a listening government, and we want to really make sure that we hold the bull by the horns.
This one there is urgent too. This one is urgent. Let me go back to Dr. Brako. I can see he has a lot of things in his head he wants to share. Doc.
I think all is well said. What we need to do is to come together as one people and see whether we'll let the system work. We have a lot on paper, okay? We have the newborn health strategy and action plan, which has all that we are discussing here. We have newborn strategy or standards of care. Everything is written inside nicely. You can take a pen and underline them as you go. But it's the implementation. The implementation. So we need our global partners. We need to make sure we identify the problem of which we have. So now we have to move and make sure we address it. It's not going to be easy, but if you take it in phases, it means we have the short term, which it's really elaborated there nicely, and then we have the medium term, and then the long term. And for Millennium Development Goal 1, we tried and implemented the short-term measures. So we had some good results.
Okay.
Unfortunately, it's faded out. All the people who have been trained are almost out of the country. So we are not going to continue, but rather go back to that phase again so that we get accelerated growth, good, fast initiative, good outcomes, so that we can continue. I don't think we have to jump to step 2 if step 1 really had gone down again. That's why our data is going up. Okay.
Thank you, Dr. Brako. I think my sister also has something to say. Please mention your name and let's hear you, please.
Thank you, Ifya. So I represent the Society of Obstetricians and Gynecologists of Ghana.
Okay.
As professionals who deal directly.
Your name, please.
Dr. Annabelle Amina Bawa.
Okay, Dr. Bawa.
Yes, please. I'm a specialist obstetrician and gynecologist at the Greater Accra Regional Hospital.
Okay.
So, as professionals who deal closely with prematurity and newborn care, in fact, our practice is intertwined. I believe that there's a hen and the egg.
Mm-hmm.
It takes a healthy young woman, a healthy woman in her reproductive years, to have a healthy pregnant woman, and then go on to deliver a healthy baby. Our care starts right from puberty through the reproductive years. And one important aspect of our care that I would emphasize on concerning our discussion has to do with preconception care. We are going beyond antenatal care to preaching and spreading the message, educating young women about preconception care. Just as you would sit and consider before embarking on a major project, a major task, in the same vein, pregnancy is no mean a journey.
Yes.
And appropriate and timely preconception care will identify risk factors. So a woman who's not fit, let me put it that way, to carry a healthy pregnancy is identified. Modifiable risk factors are dealt with. So the issue about non-communicable diseases, as Chairman mentioned, we have several of our decisions to deliver babies before their time, resulting from preeclampsia and eclampsia, hypertensive disorders in pregnancy. It's a leading cause of morbidity, mortality in our region. And I just know and I believe that if more women take up preconception care, you are identified as hypertensive, you are optimized, your numbers are controlled, you stand a higher chance of going through the pregnancy without complications. However, when midway in the pregnancy we start to pick up these problems, then we are a bit too late. And often our hands are tied and we have to end the pregnancy before time and end up increasing the number of premature babies we are having. And these babies are brought out to face all the challenges we've mentioned. I want to add that it's not just leaving it there. As obstetricians, we have the PrEP bundle. We prepare such mothers. We look at the mother, we look at the baby to ensure that even as they are being born before their time, they stand a chance at winning. So I'll just reiterate antenatal corticosteroids, magnesium sulfates, early delayed cord clamping for healthy babies, early institution of breastfeeding. Now we are starting breastfeeding right on the operating table for those who have a cesarean section and those who are on the labor ward. Right after baby is out, placenta is delivered, we start breastfeeding, and we encourage that because we know the benefits. We also talk about kangaroo mother care. This has been dealt with very well. So I want to conclude by saying that there's a place for improving the statistics. And that place starts with healthy sexual and reproductive health in young women, preventing infections right through to when they fall pregnant, and ensuring that pregnancies are healthy.
Thank you so much, Dr. Bauer. Because of time, we have to cut you for, sorry for that. So let me take the final comment from UNICEF. I mean, the way forward. Dr. Kwati.
All right, so thank you very much, Ifya. And let me just start by saying a big thank you again for someone who has spent a significant part working in newborn care units. I don't think I've seen a platform like this dedicated to preterm. So in fact, I'm really, really happy. And thank you again to Joy. The last thing I'll say is that we know what works, as Dr. Bracco said. There are some investments we've done. You go to places like in Tampon North, Wild West with Child being the Cherry Pony, where we put newborn care units, and you'll be happy with the results we are seeing. So with the commitment we are having, I believe that from all partners, I believe that we can do more if we really, really invest. And I want to say that let's let the advocacy continue. And to all partners that come on board, I believe that there is no better return on investment than a death averted. So let's see it that way, and let's help our preterms. Thank you very much.
Thank you so much, Dr. Peter Kwarteng. So I think I have to take the final comments from my Professor Alexander Ansa Menu. Prof.
Thank you very much. And I would finish by saying that a true reflection of our humanity as a country is how we treat pregnant women and babies. Should I say it again? A true reflection of our humanity is how we treat pregnant women who give life and the babies that are born. In every home, when you have a visitor, we treat them differently. Our babies are visitors into our world. We should receive them well. But I have some suggestions that I want to put across. The first one is about engagement. There's one aspect of our social life in Ghana that we are not harnessing in health. One is the churches, and the other is the chieftaincy platform. Look, there's no community in Ghana that if the chief says that anybody who gives birth should come and write the name of the baby there, so that the chief is going to negotiate for them to get birth certificates, they won't do it. There's so much respect. But I think we do not have to divorce that system from our healthcare system. I've been to places and I've seen that increasingly government is setting up what we call the district health or district council, which involves both the clergy, the chiefs, and also the health system. I think we need to strengthen that better. And also the pulpits are strong places. If Rev gives this testimony in church, and I'm sure he has, there are so many lives that will be transformed because they would have seen him growing up and they would have seen what he's become. But also telling people that, look, you cannot handle it alone. Go to the hospital when you need care. The other thing that somebody just sent to me is for us to, I must be honest, at the level where Ghana's mortality is, simple things will not change a lot of the things that we want to change. Like Dr. Bracco said, and other people have said, we need CPAP machines in every district hospital. There should be specialized newborn care units in every district hospital. UNICEF is taking these up in some of the hospitals in some of the northern regions. We need to be able to harness our development partners and government's input to get special care newborn units in every district hospital in the country.
Thank you.
There is also the need for corporate partnership. When I was in Kolebu, we had some of the floors in obstetric and gynecology adopted by corporate organizations, and they renovated them. We can give corporate bodies the opportunity to come into our hospitals and come and adopt NICUs and improve them. Many people would be worried about putting their money into a common basket. But if they have a dedicated project that they can put money into and know that they can put their name on this NICU or this special newborn care units, they will be happy to do.
Thank you.
So I think that is where we should go.
Thank you so much, and thank you, everybody, for your time. We are really grateful for your insightful conversation. Thank you so much, my audience, everybody. I'm grateful for having me. My name is Efia Amankwa Tamaklo. Thank you.